Welcome back to AMC Decoded. Today, we are breaking down a classic high-yield hematology case in our MCQ series, question number 10. This question will test your ability to differentiate between life-threatening blood disorders that look very similar on the surface. Let's look at the case. A 34-year-old woman presents to emergency department with sudden onset confusion and profound weakness. Her partner reports that she has had a severe headache for the past 2 days. She takes no regular medication, denies any GI symptoms or travel. On examination, her temperature is 37.9 degrees Celsius and she is pale, with scattered petechiae noted on her lower limbs. Neurological assessment reveals a fluctuating GCS and mild focal weakness in her right arm. Urgent investigations reveal a hemoglobin of 78, platelet count of 14, white cell count is within normal limits. Her creatinine is 110. Coax studies are all normal. A blood film demonstrates numerous schistocytes and the direct antiglobulin or Coombs test is negative. What is the most likely diagnosis? Option number A, immune thrombocytopenia. B, typical hemolytic uremic syndrome. C, thrombotic thrombocytopenic purpura. D, disseminated intravascular coagulation. And E, Evans syndrome. I want you to pause the video right now and lock in your answers. The correct answer is C, thrombotic thrombocytopenic purpura or TTP. Let's decode this. This is a classic presentation that follows the Pentad of symptoms. To remember this, we use the mnemonic FAT-RN. Let's break it down. F is for fever, which our patient has at 37.9 degrees Celsius. A is for anemia, specifically Microangiopathic Hemolytic Anemia or MAHA. We know this because of the low hemoglobin, the presence of schistocytes, and the negative Coombs test. T is for thrombocytopenia. Her platelets are 14, which causes those petechiae. R is for renal abnormality. In TTP, renal issues are often present, but usually they are mild, like her creatinine, which was 110. N is for neurological abnormalities. Now, this is the hallmark of TTP. The headache, confusion, and focal weakness strongly point to TTP over all the other diagnoses. Remember the key AMC concept. You don't need all the 5 symptoms to diagnose TTP, but the combination of fever, anemia, and thrombocytopenia with neurological abnormalities and normal coagulation studies makes TTP the diagnosis of choice until proven otherwise. To help this stick into your memory, visualize the FAT-RN. Picture a nurse with a thermometer in her mouth, which represents temperature or fever. Pale skin, which represents anemia. Spots on a skin for petechiae caused by thrombocytopenia. Confusion or stars around her head for neurologic symptoms. And she connected to a dialysis machine, which represents renal involvement. So, what is actually happening inside the body? This is a thrombotic microangiopathy. Essentially, That is an injury to small blood vessels such as arterioles and capillaries, which leads to formation of platelet microthrombi. Because the platelets are getting used up in these clots, you get thrombocytopenia. And as the RBCs or red blood cells try to pass through this clogged vessel, they get sheared or tear down, leading to MAHA and seeing schistocytes. These clots eventually block the blood flow, hitting the brain or CNS and kidneys the hardest. For your exams, you need to know the mechanism. TTP is usually caused by a severe deficiency of the enzyme ADAMTS13. Without these enzymes, the ultra-large von Willebrand factor multimers trap platelets, causing the clots. This is distinct from STHUS, which is hemolytic uremic syndrome caused by Shiga toxin, exactly. And the most common culprit is an infection of E. coli O157H7. Finally, let's quickly rule out the distractors so you do not get trapped or confused during the examination. Option A. Why not ITP? ITP is an isolated low platelet count. These patients aren't that sick. They don't have fever, confusion, or cystocytes. Option number B. HUS or hemolytic uremic syndrome. HUS looks similar but usually follows bloody diarrhea and is dominated by severe renal failure. Our patient had prominent neurological symptoms. Now, option number D, disseminated intravascular coagulation. This is the most common trap. In DIC, the clotting factors are consumed. So, the PT and APTT would be prolonged in DIC. Our patient had normal coagulation studies which rule out DIC immediately. Option number E, Evans syndrome. Evans syndrome involves autoimmune hemolytic anemia. That means the Coombs test would be positive. Our patient had negative Coombs test indicating mechanical damage, which will show schistocytes and not the autoimmune one. That brings us to the end of this case. If you found this explanation helpful, please like, share, and subscribe for more high-yield AMC content. I'll see you in the next video.